for who never came here and watched our presentation. I'm Khadija Zaki, a medical student in my 7th year. So we will start the presentation by a case of a 59 years old hypertensive patient present to the emergency complaining of dull central chest pain for around 4 hours. His vitals are as follows: a heart rate 99, the blood pressure is 155 per 95, the respiratory rate is 21, and the saturation on room air was 97%. Clinical examination, no palpable deformities or crepitus. Cardiac and pulmonary auscultation are normal. We will start our first question, but what test should be requested? I think I already showed you the right answer by mistake. I don't know if you see it or not, but we have the chest X-ray, electrocardiogram, troponin, or biology report. I will give you some few seconds to think and write your answer on comments. We have here the case presentation, 59 years old, hypertensive patient, male, present to the emergency of adult central chest pain around 4 hours. What the test should be requested? Okay. Okay, we have here E, B, C. We will give some time for Yusuf to write the answer also, and for the other to write their answers on comments. For the right answer are the chest X-ray, electrocardiogram, and troponin. They are the right answer for this question. So the chest X-ray is normal, troponin level is pending, it means en attente, and he was given an intravenous morphine for his chest pain. The electrocardiogram is as follows. I will give you a few minutes to see the electrocardiogram and to say what's the suggestion of the electrocardiogram. We can see an angina pectoris, myocardial infarction, cardiomyopathy, or pericarditis. We have four answers, but it's one who is correct. We'll give you some time for reflection. B, okay. Nice. So the correct answer exactly, it's B, a myocardial infarction, and that's because we have a chest pain, and in electrocardiogram we have a T-wave inversion suggest. So we suggest a myocardial ischemia. I make here some notes for the other diagnoses, why we didn't put them correct also. For the angina warns of reduced heart blood flow, causing chest discomfort without permanent damage. Myocardial infarction, it's through because we have a sudden blockage lead to severe pain and the possible heart damage. Cardiomyopathy, it cannot be correct. It's a heart muscle disease. Often it will be a gradual rather than causing a sudden chest pain. For pericarditis, as all and the majority know, it's an inflammation around the heart causing the chest pain, typically presenting with a widespread ST segment elevation. I mentioned here, I see a comment. I mentioned here why we put a myocardial infarction, why it's correct, because when we have a chest pain, a sudden chest pain, and we have a T-wave inversion, we suggest for the first term it's a myocardial ischemia. The first diagnosis to suggest it's myocardial ischemia. For the third question, in this case, two drugs should be given immediately. We have aspirin, a low molecular weight heparins, fondaparinux, or we have both A and either B or C. We have two drugs that we must give it immediately. A and C, okay, D. I will give you some more a few more seconds to answer and to write your answer on comments. So the right answer here is D. Both. A, we can give aspirin or low molecular weight heparin, or we can give aspirin or fondaparinux. Both A and either B or C. We choose one of this molecule. So the correct answer is D. For our fourth question, what if the electrocardiogram shows a features of left main coronary artery occlusion, which mean a widespread ST depression plus a ST elevation in AVR? We have a stress test, repeat electrocardiogram in a few hours, emergency coronary angiography or surgery. What we should do? We already talked in other presentation about the left main coronary artery occlusion, so you can find it on YouTube channel. Yeah, you can write your answer. Okay. I think all of you answered correctly. So the correct answer, yes, it's emergency coronary angiography. Correct. I think all of you answer correctly. We have here a home note to take. You can take a picture of it. We have a patient with ischemia chest pain. Of course, we will perform an electrocardiogram. We will see if we have an ST elevation or a non-ST elevation. After that, we will move to the troponin. We will see if it was normal or raised. If it was normal, which means an unstable angina, or if it was raised, we will think about a non-ST elevation and myocardial infarction. If it was ST elevation, we will think about the ST elevation myocardial infarction. We have here how to difference between the three of them. We have an unstable angina. It's an occlusive thrombus, non-specific electrocardiogram, and with a normal cardiac enzyme. The non-STEMI, it's an occluding thrombus sufficient to cause tissue damage and mild myocardial necrosis. We have also on electrocardiogram and ST depression, and also we can have a T-wave inversion on electrocardiogram, elevated cardiac enzyme. And for S-STEMI, we have a complete thrombus occlusion with an ST elevation on electrocardiogram or a new left blunt blocker, which means bloc de branche. We have also elevated cardiac enzyme or more severe symptom. For the severe symptom, the classic and the most, of course, common feature of acute coronary syndrome is the chest pain, which is typically central, left-sided, substernal, but it can also be epigastric. May radiate to the jaw, the left arm, the shoulder. We have also an important information that certain patients, like diabetes, who have diabetes, elderly may not experience any chest pain, which means a silent myocardial infarction. We can also have other possible symptoms in acute coronary syndrome, include dyspnea, sweating, nausea and vomiting, or may appear pale and clammy, of course. So the other question, if the patient presents within 12 hours, what is care management? If the patient presents within 12 hours, we will use thrombolysis or percutaneous intervention. I saw here a comment that says, je comprends pas pourquoi. The chest X-ray, we must do it to eliminate the other differential diagnosis. That why we suggest also the chest X-ray. So here, the majority have says the percutaneous intervention. We will wait a few seconds for the other to write their answers also. So the right answer is the percutaneous intervention. It's correct. For the management, to take notes, it's too important. In acute setting, we give to the patient intravenous morphine for his chest pain, oxygen, nitrate, aspirin, 1300 milligram. We collect the first letter of each word to facilitate the memorization of it by MONA, morphine, oxygenation, nitrate, and aspirin. If the patient presents within 12 hours of the onset of the symptom, the primary, as you said, we do the percutaneous intervention, percutaneous coronary intervention. It's the gold standard. But if not, our percutaneous coronary intervention, it's invaluable. We move to the thrombolysis. And for the thrombolysis, we preferred the molecule alteplase over streptokinase. I have here another question. We talked about the management with acute setting, but we will now talk in a long-term myocardial infection. Which treatment we use? In a long term? I made here a mistake. Aspirin, clopidogrel, beta blocker, or statin. Okay, we'll give you a more second to write your answer. Okay. Yes. So the answer is the beta blocker. In a long-term management of myocardial infarction, which treatment we use just for 12 months. Like here, we have aspirin, clopidogrel, beta blocker, and statin. One of them, we used it just for 12 months. All of the other, we use it whole life, aspirin, clopidogrel, and statin. But the beta blocker, we use it just for 12 months. To explain that, why we use the beta blocker for 12 months only, not like the other. After heart attack, the beta blocker help the heart recover by reducing workload and stabilization the heart rate. The guidelines, of course, advise using them for around 12 months post myocardial infarction to prevent complication. A continued use depends on individual factors, of course, and should be discussed with a healthcare provider. So the guideline says that the beta blocker, we use them just for 12 months, but the other, of course, we will use it the whole life. The patient must use it her whole life. We have here a note to take with you. You can take a picture of it. For the chronic or long-term management of myocardial infarction, also we have here a word to simplify and to memorize the treatment, which is the AABC plus S, which means aspirin, ACA inhibitor, which means the angiotensin converting enzyme, beta blockers, and clopidogrel plus the statin. I also add a random question about the chest pain. The seventh question. A 45 years old woman with no significant medical history present to the emergency department with a sudden onset sharp stabbing chest pain that worsens with deep inspiration and coughing. The pain is located in the left pleuritic region, sharp pain that worsens with breathing. She denies any history of heartburn, indigestion, nausea, vomiting, or shortness of breath. The question is, what is the most likely cause of this patient chest pain? Myocardial infarction, the musculoskeletal chest wall pain, a pulmonary embolism, or esophageal spasm? I'm waiting for your answer and comments. Yes, what about the other? What is your reflection about this case presentation here? We will wait for a few seconds. The majority answer by C. We have one answer by A. What about the others? Okay, so we will move, I think, to the answer, to the correct answer, which is a pulmonary embolism. Why A it's not correct? Because I see some of you mentioned the answer A. For myocardial infarction, it typically wouldn't worsen specifically with a deep inspiration or caffeine, although it might worsen with exertion. And additionally, the lack of risk factor, like no prior medical history, make this answer slightly less likely. So the correct answer is pulmonary embolism. This perfectly, I think, fits the description. Pulmonary embolism often cause a pleuritic chest pain, which works with breathing and can occur without prior medical history. Let's move now to the other question. What is the most common type of embolus involved in pulmonary embolism? We have atherosclerotic emboli, fibrinochorionic emboli, gaseous emboli, septic embolus, metastatic embolus. What is the most common type of it? Okay, we have here B, C, multiple answers. Okay, A. I will wait a few seconds, like 5 seconds, 6 seconds. Now we will move to see the correct answer. Okay, B. So the correct answer is B. It's a fibrinochorionic emboli. Why? The pulmonary embolism involves the sudden blockage of a pulmonary artery, typically by a blood clot originating from a deep veins in the legs, known as a venous thrombi. These thrombi are primarily composed of fibrin and red blood cells, which corresponding to a fibrinothrombotic emboli. That's why the correct answer is B. Other question, what is the most common electrocardiogram sign of pulmonary embolism? Sinus tachycardia, ventricular tachycardia, incomplete right bundle branch block, complete right bundle branch block, which mean in French bloc de branche incomplet, and for D, bloc de branche complet. For E, right axial rotation, aspect S1, Q3. Which is the correct answer. I think it must be easy. Okay, we have E. E, yeah. We will wait for a few seconds, as usual. For the other, of course, feel free to write your answer on comments. We will wait another 5 seconds. So for this question, the correct answer is A. All of you answer correctly. For the S1Q3, the S1 refers to a prominent S wave in lead 1. G1, and for the Q3, it refers to the presence of a deep Q wave in a lead 3. That's why we have this aspect in pulmonary embolism, which is S1Q3. I don't know if it's the last, but the question says, what are the 3 most common causes of tamponade? We have benign acute pericarditis, hemopericardium, tuberculous pericarditis, neoplastic pericarditis, and purulent bacterial pericarditis. Pay attention to the question. I didn't say causes, I say the 3 most common causes of tamponade. Okay, write your answer on comments. Okay. I see an answer by A, C, and D. Okay. What about the others? What do you think about the 3 most common causes of tamponade? Okay, we have A, D, and E. Okay. Okay, we will wait for the others. Few seconds. We have B, D, and E. Okay. The others. So the correct answer of this question, it's A, B, and D. The benign acute pericarditis, hemopericardium, and neoplastic pericarditis. Remember it. These are the 3 most common causes of tamponade. Yeah, as I said, it's the last question. So for conclusion, the chest pain's origin can vary. A heart attack, blood clot in the lung, or fluid buildup around the heart are all possibilities. Each has distinct symptom and requires specific diagnosis. Early action is key. Recognize warning sign and seek medical attention promptly for optimal, of course, outcome. So thank you for your attention.